Good morning, everyone, and welcome to the UNC Health Game Changer series. My name is Leslie Nelson Bernier, and I have the privilege of serving as the president of the UNC Health Foundation, and we're just delighted that you're with us today. As we were showing in the slides leading into today's talk, please do feel free to use the question and answer feature at the bottom of your screen if there are questions that you would like to ask. I'd also encourage you to use the chat function if you want to chat with the panelists during the course of today's talk. We also have many submitted questions from you all, so like always, we will try to get to as many of those as we possibly can. So to kick us off, I would like to introduce you to our Dean of the UNC School of Medicine and CEO of UNC Health, Dr. Wesley Burks. Wesley?
So thank you, Leslie, and thank the rest of you for taking time to join us on this next edition of Game Changers. Our guest today hopefully will be familiar to many of you from our previous events, or certainly if you've been watching the news during the pandemic, where David's been a constant and reliable source of really good information. So to introduce him officially, Dr. David Weber is our Charles Addison and Elizabeth Ann Sanders Distinguished Professor at the UNC School of Medicine. And he's really an internationally leading expert in infectious diseases and infection prevention. So we're thankful and honored he's here and be able to share the information, his knowledge today. He's going to talk some about the latest trends, some information on boosters, and a lot of details that I think you'll find fascinating. Just from our personal standpoint, from a system standpoint, just one brief update on COVID-19, and I know David will allude to this as he talks in a few minutes. Across our systems, across the state, the 15 hospitals or systems that we're affiliated with right now, we're more than 50% less than we were 6 weeks ago with COVID positive patients, which is really good. We're not seeing that same rapid increase we were 2 months ago. But even with the decline, it's still a lot of people in the hospital, particularly in the intensive care units, mostly in the unvaccinated, but still we have a lot of people in the hospitals. The predictive modeling that we've done shows that we should continue this decline for a while. And I know David will allude to that, some of the concerns he and others have about kind of the what next, the question that certainly that all of us have. So with that as an introduction, David, we're thankful that you're here and look forward to the conversation and the discussions that we can have. So please go ahead.
Thank you very much. As always, it's a great pleasure to be talking to you today. And we'll bring up my slides. And I know we all have COVID fatigue. It's been almost 2 years, but we do have some good news here on the horizon. This is a conceptual. I want to talk about the public health impact 2 years into this outbreak. This is a conceptual framework of factors affecting the pandemic's trajectory that was done by the National Academy of Social Insurance. And I was a member of the working group that developed this. It shows, importantly, the host vulnerability, and there have been disproportionate impacts on people based on both gender, age, ethnicity, and other factors. Obviously, secondary immunity, which we will not reach. I'll talk more about that. Immigrant status and others. We've had our mitigation efforts. Principally now vaccines, the best one, but masks and physical distancing. We've also used testing. We have had a number of new treatments there, including monoclonal antibodies and drugs. And then we have the indirect effects that this has had on the economy, education, stress, non-COVID healthcare, which has been delayed, and social inequalities. And outcomes, of course, I'll talk about more: hospitalizations, deaths, short and long-term disability, and of course now supply chain problems, which didn't even make it into this list. Next slide. So here we are now with worldwide approaching 5 million deaths, 5 million cases, sorry, approaching 250 million deaths there. If you look down at the bottom left, this is the time course of COVID worldwide. I do want to point out, despite the now dropping cases here in the United States, worldwide, if you look at that slope of that curve, this pandemic will go on for a number of months to come. There's no evidence worldwide it's tailing off. if you look at the impact on cases around the world, of course, we don't have very good surveillance in Africa, so the lack of large dots there should not be taken as meaning it spared that. But you can see the large number of cases, South America, the United States, Europe hard hit, and Asia very hard hit as well. Not many cases in Australia and New Zealand because they still remain using the lockdown as their principal means. But again, a classic true pandemic. Next slide. And what I've done here is I plotted deaths from wars and pandemics to put it in perspective. My data on COVID-19 is already a little old at 10/6, but a few weeks ago we'd had 705,000 people perish from COVID, a horrendous toll. Notice that this now eclipses the number who died from HIV/AIDS. Of course, that pandemic still ongoing, but now on the order of 50+ years old. And we have exceeded the number from the 1918 Spanish flu, although the population of the US was much smaller then. But essentially, we've exceeded now the deaths in all the major wars in the United States going back to the Persian Gulf War. I do want to point out that the University of Washington, they are forecasting for January 1 of 2022 is that we will lose another 80,000 plus Americans between now and then. So again, although the numbers are dropping, the toll from this disease continues at just a remarkable pace. Next slide. To put it in perspective, COVID was in 2020 the third leading cause of death in the United States. Only heart disease and cancer caused more people to die. Most recently, if you look at the most recent month, September, COVID was the second leading cause of death, surpassing cancer. And in other spikes, such as the January through March spike we had at the beginning of the year, it also exceeded that. So the average number of cases there, heart disease, are about 2,000 deaths each day, cancer 1,600. In September, roughly 1,900 people were dying of COVID every day, coming very close to becoming the #1 leading cause of death in the United States. Next slide. Now, if we also saw this with the 1918 pandemic. I just show you some data here on the left for the United States and for the UK. So just to prove this is not a worldwide, this is a worldwide phenomena. So I want to point out to you that this disease is having an impact on actually lowering the life expectancy in the US and the UK. I also want to point out very importantly on this slide that in the United States it's had a disproportional impact on Latino and Black Americans. This is not related to any predisposition genetically to the disease. And when those individuals reach the hospital, our medical center, the rate of mortality is similar when you correct for underlying comorbidities, regardless of ethnicity or race. So this all represents burdens of inequities in society, unequal access to vaccines and to medical care, having to take jobs that expose people more. And so this inequity is a very important one to realize as well. Next slide. So this was from the Robert Wood Johnson Foundation there, just again to tell you some of the impacts that this has had on society. For larger cities, serious financial impacts. More than half the households have depleted savings. Many of these, as we've mentioned, concentrate on Black, Latino households, households with incomes below 100,000, experiencing job or wage loss. At least 4 in 10 Latino, Black, and Native American households have used up almost all of their savings. 20%, 1 in 5 households report household members unable to get medical care for serious problems. We are so full of COVID and people are worried about coming and sitting in clinics that people with other diseases, heart disease, cancer, are unable to receive care or are worried about coming in and being exposed to COVID. 1 in 3 households that include anyone with a disability face serious financial problems. More than 1 in 3 households with children face problems with maintaining their children's education among working adults there. 20% are having problem getting child care. And 1 in 3 households with children either do not have high-speed internet at home or report serious connections, disadvantaging their children and maintaining their education. Next slide. Now, impact of COVID worldwide and the U.S., you can see the global GDP forecasts. The United States has had one of the smallest negative impacts, but you can see that all over the world, a tremendous decrease in finances, which will be equated to an unforeseen initially impact on lower income individuals there. Just down there, when you look at the lockdowns there, this is the impact on planned cancer therapy for 15 tumor types in 61 countries. And again, just showing you the unintended consequences of the lockdowns on providing other medical care, which is certainly disadvantaging many individuals. The U.S. share of population working full-time, part-time has had a tremendous drop, although it is recovering somewhat, as you know, and we're expecting a substantial increase in extreme poverty throughout the world due to COVID. Next slide. Cases and deaths, just some of the disparities here in the United States. You can see here, again, Black and Latino individuals with substantially higher mortalities. Again, this is due to increased risk for acquisition, less access to health care prior to coming into the hospital. But this is an ongoing issue that we at UNC and many other institutions are working very hard to ameliorate by providing better access to therapies, vaccines, and care. Next slide. Now, what about the issue of impact of vaccines and deaths? This is just some recent data just put up on the CDC webpage on the 11 on this topic just a few days ago. A 6-fold greater risk of testing positive for COVID if you're unvaccinated, and an 11-fold greater risk of dying from COVID if you're unvaccinated. Over 90,000 deaths since June would have likely been prevented with vaccination. This remains a major problem in the U.S. We'll talk more about that at the next session, where about 20 to 30% of people in the U.S. are vaccine resistant, and that has not changed since December. And the U.S. now, while we were back in January #1 in providing vaccines for our population, we rank now about 45th in the world for the number of vaccines that we have provided. But there's no question that vaccines work and have saved thousands of deaths in the United States. Next slide. Mental health issues. This I'm focusing on healthcare providers here. Among 26,000 respondents there, these are really among frontline workers, health workers. 53%, more than half, just in the last 2 weeks reported depression, anxiety, PTSD, suicidal ideation. This is a problem throughout society, but particularly with all the stresses, working while dealing with childcare and all the other issues, working in medicine and in front lines has led to tremendous stress and tremendous mental health problems. Next slide. Long hauler syndrome, I just wanted to talk about that very briefly. We break down many people with COVID, even those who have had very mild or even asymptomatic infection can have prolonged problems. We talk about post-COVID disease, meaning 4 weeks afterwards, and chronic COVID going on for 12 weeks. You have acute infection, the inflammatory phase and recovery. There's a tremendous amount of inflammation that affects all the organs. And just when you are no longer infectious and leaving the hospital or at home feeling a little bit better, many, meaning 20 to 40% of people have ongoing symptoms. Next slide. So here is just the some of those that essentially affects every single body site. This was a retrospective study of 81 million people, 273 COVID survivors. Among those, you can see 1 in 3 patients had 1 or more features of long COVID between 3 to 6 months. 2 in 5 of those patients who had those features had no record of it, meaning, so this is not just exacerbating underlying disease, but creating new problems. I would point out that our long-haul COVID clinic under the direction of John Barata has now seen over 400 patients. UNC Health was the very first health center in North Carolina to develop such a clinic. It still remains the largest clinic, and certainly funding from the Dean's office and Dr. Burke's support and your support was critical to getting this important clinic up and running. So even if COVID miraculously disappeared tomorrow, we're going to be dealing with potentially patients with long disabilities for months and potentially years to come. Next slide. And so this was a paper I did with Dr. Henderson and Dr. Hassler. Dr. Henderson, a former deputy director of the NIH Clinical Center. We made some missteps in the past. We didn't have a coordinated federal response. The executive branch trivialized COVID initially. Our public health structure is inadequate. We were very slow in developing testing. We didn't have adequate supplies of personal protective equipment, and we initially failed to focus on nursing homes. We still have ongoing issues that all of you can help with: science denialism, politicalization of the pandemic response, vaccine resistance. We'll talk more about vaccines for children. That might be a bright spot in the future. We continue to see a spread of more transmissible virulence. 100% of them are now the Delta variant. Post-COVID clinical issues, which I mentioned, lack of public support, and we continue to see it for mask mandates. We'll see about the need for recurring boosters, and we'll talk more about that. I can guarantee you there'll be some unanticipated challenges, and so we need to remain flexible, and we're all feeling pandemic fatigue. Thank you very much.
So David, thank you. There are several questions, I think, related to this part that I'll try to walk through. The first one's a really practical question, and it was sent in earlier that basketball season in Chapel Hill is about ready to start. And the concern, or how concerned would you be personally and give advice to others about going to the Dean Dome if you have a mask on? I mean, people been to football games, some have, some haven't, but this is different. So how do you feel about it, Dave?
So I think if you've been vaccinated, which is the best prevention strategy, and you wear your mask, I think it is relatively safe to go to a basketball game. I think the one issue, as we saw, unfortunately, with General Powell, is that if you are highly immune suppressed, as he was, even with both vaccines, they don't work as well, and even wearing a mask, I think I would avoid that type of congregate setting. But otherwise, I think wearing a mask and being vaccinated, you can safely attend most of those indoor events.
Oh, good. So I feel better already. So the next question I think is difficult, and one that's been raised for the last 18, 19 months by a number of people. But the question is that we frequently get pushback, even in the healthcare space, from calling a death due to COVID when the patient had cancer or heart disease or other comorbidities in which they might have died in the near term. So go through the process of how somebody that said they are dying from COVID. What happens? How does that happen?
So of course, when someone dies, the physician fills out the death certificate. That information is based on the death certificate, which we do have the proximal cause of death, which might be heart failure, and secondary to, and it would be COVID. It's certainly true, but we don't do this for any other disease. If someone comes in with the car accident and dies, but had cancer that would be terminal in 2 months, we don't list it as a cancer death. We list the immediate cause of death is COVID. So we're not treating COVID any differently than anything else. It's very hard, except in very extreme cases, to predict how long someone might live. We have patients with metastatic cancer who live months to years, and now with new experimental therapies, or now actually approved therapies such as CAR T, we save them. And we have people with severe heart disease who end up being heart transplant candidates or home use of a cardiac machine. So it's very hard to predict that. And so unless somebody was immediately terminal, in which case we wouldn't count it as a COVID death, but that's very tiny. We count them. We actually have undercounted COVID deaths, not overcounted them, because particularly early in the epidemic and in places like New York City, they were so overwhelmed that patients who were in nursing homes and did have chronic diseases were not being admitted and not being tested. So if anything, the number that I showed you is an undercount.
Yeah. So the next question, David, is that you alluded to it in your misconceptions, things that had happened during the last 20 months, but as a leader, what do we need to do, or what needs to be done to restore some faith in the scientific leadership?
I think all of us need to work at different levels, starting with our own families, friends, colleagues, and be beacons for providing the correct information that you can find widely from CDC, professional societies, your own training there. Beyond that, whenever we should be open to talking to the news media, providing accounts there, and in our articles, publishing our experience. And whenever possible, we should rely on not anecdotes, but rely on well-designed scientific experiments like we do in general for medicine. I find it particularly distressing that there are a number of physicians, some of whom have risen to prominence, that continue to promulgate clearly untruthful aspects of vaccines and COVID mitigation when the data supporting them is just overwhelming.
Okay, thank you. So talking about that data, there was a question from earlier about the strength of the evidence that's there from 100 years ago and this pandemic about the use of masks, particularly when we talked about it from a public standpoint, dean-dom, but really from a school standpoint in the elementary age, middle school, high school, the use of masks and the data coming out of that and its prevention.
So I'll mention a couple of quick things here. At UNC hospitals, we've taken care of over 1,500 COVID patients. In that entire time, in our multiple COVID units, pediatric, psychiatry, medicine, surgery, giving care to those people 24/7, we've only had two, and I say two possible cases of patient to provider transmission, despite essentially hundreds of thousands of person hours taking care of them. That shows you, and this is often pre-vaccine, how well our mitigation efforts work of hand hygiene, masks, surface disinfection, and others. If you look at our patients in the hospital in the last 3 months, roughly 85 to 90% of those who were in a non-ICU bed with COVID were unvaccinated. 95% of those in the ICU were unvaccinated, and virtually 100% of the deaths were unvaccinated. Of those vaccinated people who were in the hospital, much like General Powell, 2/3 had cancer, organ transplant, or high-dose steroids. So again, showing you how well all of this works. And there's much more data. I'll mention one study I've done. So I only fight with Duke on the basketball courts with my colleagues there, but I'm part of what's called the ABC Collaborative, which is a Duke UNC group that studies COVID in elementary K through 12 schools. During the peak January through March, for every 20 community-acquired cases in children in those schools, there was only one case of a school-acquired case. So we were largely, not perfectly, but largely able to protect our children in K through 12 schools, even during a surge with masking and physical distancing, such that we reduced their risk from acquiring COVID 95% being in school compared to just being out in the community. There's no question that the mitigation strategies have been highly successful, and they've been very successful here at UNC. There is not a single student right now in quarantine, and in the last week, I think we only had one student convert and develop COVID. So again, at the university level, we also have been highly successful.
No, it's amazing to see when people follow those guidelines, how well it's happened. So one last question on this part. If you put on your crystal ball and look to the future, we're right now in North Carolina and as a system predicted to be like around the 1st of December, back where we were in July as far as overall number of cases. So what do you see, December, January, February, and beyond for this particular pandemic?
So I do see the cases falling, and barring a new more virulent or transmissible variant coming out, falling. COVID, SARS-CoV-2 is and will become endemic. We'll have to deal with this in the future. That's the good news, but I see an increasing disparity in the population. So the people who've had their booster vaccines and continue reasonable mitigation efforts, and particularly as new drugs and new therapies arrive, will have a very low risk of having a serious COVID. On the other hand, that 20 or 30% that are highly vaccine resistant and deniers of coming in and seeking care early will continue to have a substantial morbidity and mortality going out, I think, at least through next summer from SARS-CoV-2. And the disparity between those following, taking the medicines and following the vaccine and mitigation and those not will become increasingly large, both by geography and within each locale as well.
Okay, thank you, David. I appreciate that. So let's go ahead to the second part of your presentation today and talk about some vaccine information and also some new treatments that are exciting.
Yes, thank you. So decreasing cases, you've all heard that. But I do want to point out, despite the decreasing cases, virtually every county in North Carolina and the United States still has high transmission, but I think it will fall. I did mention that the number of deaths will still have a horrendous toll. The Delta variant here, we sequence every case at the medical center and across the United States is still the most predominant one. The booster doses of Moderna and J&J were recommended by the FDA panel last week. The ACIP, well, we're talking, the ACIP is talking, and we'll look at that. There's no question in my mind that they will approve booster and J&J vaccine doses. What I don't know yet is whether for J&J they will also recommend a mix and match approach of giving them either a J&J booster and then an mRNA vaccine, or just moving to an mRNA vaccine. We'll have to see by the end of what happens by the end of tomorrow. UNC hospitals will begin giving those booster doses likely early next week. Next week, the FDA will meet to talk about the PFIZER vaccine, ages 5 and 11. I'll come back and talk about that a little bit more later. CDC and the professional organizations now have an increased attention of vaccinating in pregnancy. Nothing is more harmful to a fetus than a sick mother. And unfortunately, pregnant women have a much higher risk of serious outcomes with COVID. COVID vaccine becomes only the third vaccine specifically recommended in pregnancy, along with flu and Tdap. The FDA has a new home test kit, and the U.S. is working on making those available. Two new exciting things are molnupiravir. This is an oral therapy that could be used to treat mild to moderate COVID. You won't have to come into the hospital. The FDA will look at this towards the end of November. There are no papers on it, just press releases, but it was about 50% effective. We are meeting already now. I should say, by the way, UNC, Mike Cohen and Billy Fisher, two of our expert physicians, led one of these trials with this new drug. How it will fit with the monoclonal antibodies, we're already working on our algorithms. Another new exciting drug is the AstraZeneca drug here. This is a long-acting antibody. It's given IM, so you don't have to go to an infusion center. 2 doses and provides somewhere between 9 and 12 months of protection with a risk reduction of acquiring a symptomatic infection by about 75%. Again, a game changer, potentially very useful in immunocompromised people and potentially for the vaccine-resistant group. So new things on the horizon, all good news. Good news, cases, hospitalizations falling there, and you can see that here, as well as deaths there and hospitalizations. To the right are what's happening with the Delta variant. You can see here now for several months, it is by far the predominant variant. And you can see the impact, by the way, during the surge on younger adults here in the upper right. Those are younger adults, really disproportionately affected by the most current surge because of loosening up in society and the higher transmissibility of the Delta variant, plus children under 12 not eligible for vaccine yet. So a disproportionate effect on younger children. Next slide. Here are the hotspots in the U.S. CDC groups them from low to high. And just to point out, despite these drop of cases, you can see that almost everywhere in the United States remains having high transmission. Next slide. In terms of vaccine efficacy, just to point out, vaccines, the CDC labeled vaccines at the turn of the century, looking back at the 20th century as the greatest public health achievement. They also said the same thing for the first decade. These have truly been a godsend. With potential exception of safe and clean drinking water, vaccines have saved more people in the last 200 years than any other public health intervention. There's COVID vaccine, 95%. We really hit a home run with COVID vaccine. The studies were powered to look only at a 50% effective vaccine. It truly is an amazingly good vaccine and is even better at preventing severe disease than preventing a mild disease there. Next slide. And just to show you the global worldwide vaccine uptake, 43% of the world has now received at least one dose, 66 billion doses administered, 225 million every day. But still, we need to make more efforts to immunize people in Africa, other disadvantaged areas, since every person we immunize is one less person who can develop a variant, and plus helping them as well. You can see how we're doing with COVID vaccine doses administered per 100 people there in the world. And you can see here the leading countries: UAE, Israel, Uruguay, China, Japan, United Kingdom. The U.S. is 45th in the world on that list of the percentage of its population immunized, and continues to drop as those numbers rise in other countries. Next slide. Again, vaccinations in the U.S., we hit a peak of 4 million. When we started immunizing the 12 to 16-year-olds, we went up a little bit, then we dipped. We went up a little bit with the Delta variant. But still, if you look at the eligible population, we're only at about 75% immunized. We've done much better in older individuals who have higher risk. But it does demonstrate there about 20% of the population is highly resistant to vaccine. Next slide. This just shows the data that I already mentioned at the UNC hospitals about the unvaccinated. You can see here in the upper right data from CDC, just showing you that the only 4% of people hospitalized from January to June were fully vaccinated. 96% were either unvaccinated, the largest group, or not yet fully vaccinated, just showing you how well the vaccines work and how important they are. I do want to point out this graph on the right. This shows you hospitalizations, fully vaccinated and not vaccinated in the United States there. It shows you, one, the age distribution, that really this disease has the most significant age distribution for increased morbidity and mortality than any infectious disease. Really, older you are, the higher the risk. But I want to point out to you, if you look at the numbers, say, for the 12 to 15-year-old group, you would see that a unvaccinated person at 12 to 15 really has a similar risk of disease as a fully vaccinated person 50 to 64. So the benefits of vaccine are less in a younger child in terms of their direct benefits, and about 1 in 10,000 people would get myocarditis. So when CDC and FDA discuss this next week, it's going to be a somewhat difficult discussion. From a public health standpoint, clearly we'd love to have children immunized. They can return to a more normal life. They won't be giving it to older adults or immunocompromised people. But the CDC and FDA are going to carefully balance the risks and benefits in children. And I don't know that it's an automatic, simple decision for them to say all children 5 to 11 should be immunized. They may leave it up to people, or they may just recommend it for high-risk children. We'll have to wait and see. Next slide. COVID vaccines in the U.S. here and willingness to get vaccinated there, just showing you where we don't even rank on that number, as you can see there in the top 20. But you can look at the number of people who are unvaccinated and not willing to get a vaccine. One, the U.S. is in the 24%, so we're higher than other places in the world, accounting for why we are so far down the list. And that number of about 20% depends on the different polls. really has not changed substantially since December. The one thing that may impact that is making vaccine a condition of employment or going to school. Many of those who say they would not get a vaccine said, if you require me to get it for work or another reason, then I'll take it. Next slide. And this very nice article in the New York Times summed up why we have vaccine hesitancy. Some are watchful, and that number, which was probably 40% back in December, has decreased as we have much more data about safety and effectiveness. Some are, of course, anxious, and really we just have to tell them the vaccine's free, and now that they don't have to miss work necessarily, widely given Walgreens, CVS, and others that can deal with that. 4% of system distrusters, many minorities, remembering Tuskegee. Those we have to get trusted members of their own communities to help air their concerns. I noticed couple of months ago, the Pope made an announcement that Catholics should and can receive the COVID vaccine. There are some issues in the lay press about use of fetal cells in those vaccines. The mRNA vaccines had no fetal cells used in making those vaccines. And then we have the vaccine skeptics. And those are going to be a very hard group to convince. And the best way to approach those is to talk about the benefits to their loved ones, their family, their children, their grandparents. And that's the reason they should get vaccinated, even if they themselves oppose it. Next slide. What about third dose immunocompromised people? You can see organ transplant people, others with cancer. The normal healthy controls are 95 to 100% effective. In terms of responding with large amounts of antibodies. And this is why already several weeks ago, we began giving a third dose to immunocompromised individuals. Next slide. And you can see here on this study that if they were immunocompromised, a much smaller number were seronegative after the third dose, and those who then converted had much higher antibody levels in multiple studies of different immunocompromised populations. I should say that many of the most severely immunocompromised bone marrow transplant patients still do not develop a perfect antibody response, so they need to continue masking, and potentially monoclonal antibodies, long-acting ones, would be helpful. Next slide. Vaccine effectiveness worldwide has decreased a little bit with Delta, although you notice it really has had the biggest impact on symptomatic disease dropping, but hospitalizations, it really remains very effective, 90+% for hospitalizations and severe disease, as I've told you, in the hospital. And this is why we're beginning to give boosters to those individuals. Next slide. And I just want to show you how well the boosters work. This is from Israel, which has been using boosters for several weeks. And you can already see that, again, this is early data, 12 days or more after the booster, they found roughly a 12-fold decrease in the relative risk of confirmed infection and a greater than 10-fold decrease in the relative risk of severe disease. Now, this is not comparing people with boosters, 3 doses, and people with no vaccine. This is booster versus 2 vaccine, a substantial improvement, and the antibody levels go up 5 to 15-fold. So data already coming in from Israel on this and other studies that boosters will have a substantial and improved impact on people getting, reducing the risk of even the fully vaccinated becoming ill. Next slide. Here, short-term, in the odds of testing positive for SARS with 3 doses of vaccine. Again, the risk dropped from no booster. Again, these are booster versus no booster, just 14, 21 days later, 75% drop in the risks of testing positive. So improves the marginal effectiveness by 70 to 85%, and that's compared to fully vaccinated people. So again, boosters really are a very reasonable and appropriate thing to be approved. Next slide. And that's my last slide, and I'm happy to answer questions.
Okay, David, that part of the presentation obviously spawned a lot of questions, and I'll start with a really very specific one that someone's asked a few times. And this is about the COVID nucleocapsid antibody. First, explain what it is and the significance of it and the relevance of it, particularly as you think about increase in age, you think about vaccination. So what's the story behind it?
So all of the vaccines that are currently available, but not all under development, are based on the spike protein. That includes our 2 mRNA vaccines, Pfizer, Moderna, and our adenovirus, a vector vaccine, which is J&J. There are other, and this is the primary way by which the SARS-CoV-2 virus attaches and is absorbed into human cells. There are other proteins on the surface of SARS-CoV-2 that could be incorporated into vaccines, and people already are working on developing that. But the mRNA, spike vaccine ones have already demonstrated such high effectiveness. I'm not sure it's necessary. The one utility of other proteins other than the spike protein is one can now, and we do it in our lab, determine if you have antibodies, did they come from natural infection or did they come from vaccine? If all you have is spike protein, then you have it's from vaccine. If you have other proteins that antibodies to, then you've had natural infection. So it does allow us in testing, which really the antibody test is an antibody test that doesn't, we don't have an absolute amount of antibody that's protective. Much is good, few is poor. There's no reason to get a test after you've had a vaccine. But it does allow us for research to determine natural immunity from no infection versus vaccine-induced immunity.
Okay, so there's a question related to really herd immunity. So we've talked about 25% of the population is just not going to get it right now. But also, particularly early in COVID, we talked a lot about herd immunity and the percentage of people that need to be vaccinated or have disease. What are your thoughts about that right now?
So based initially on the presumption that people who got disease would have at least substantial immunity, and people who are vaccinated, much like measles, would be highly immune to getting any disease. And based on the fact that the rho, meaning if I'm infected, how many people I infect on average for SARS-CoV-2 is 2 to 4, people predicted you needed to reach about 70% of the population, natural disease or vaccine, to start reducing the risk. So if you went into the supermarket without a mask, your risk of getting COVID would be decreased. It's never entirely eliminated. Right now, actually, data from a new study from the Red Cross show that about 80% of the population either has had infection or vaccine. And yet we're in the midst of a Delta surge. And because Delta is so much more transmissible, and because we see both breakthrough cases in people vaccinated, although usually mild, and reinfection in people who have had disease, it appears that unless with boosters we substantially increase immunity, we'll have to wait and see, and it stays durable, we will never actually reach so-called community protection. That means that much like measles, if you could never take a measles shot because you had certain allergies, you don't have to worry about getting measles. There really is none circulating in the US. We're never going to reach that level, at least in the foreseeable future for COVID, which means if you're unvaccinated, and particularly if you have risk conditions for serious disease such as older age, you, when you're out in the public, will need to continue masking for the foreseeable future. You will not be able to rely on herd immunity. Okay.
So there's a couple of questions I want to wrap up together. One, someone who's unvaccinated has COVID, what's your recommendation on the vaccine? The other is somebody that is vaccinated and then has disease. How long to wait before they get a booster?
So people should wait until they're no longer infectious for both, meaning 10 days. Once you pass that 10 days, if you're eligible for vaccine by being unvaccinated, and you clearly should get vaccinated, there was a nice study published by CDC a few weeks ago in the MMWR showing that people who were unvaccinated, people who had natural disease versus people fully vaccinated were about twice the risk of getting recurrent disease. So vaccine, you get some protection from natural disease, but vaccine is much better. And in terms of the booster, it would be the same thing. Just wait till you are no longer infectious and you're eligible for your booster. I should say, though, for either group, if you're vaccinated but at risk for bad outcomes, or you're just unvaccinated and you get COVID, the very first thing you should do is call your healthcare provider and see if you meet the criteria for monoclonal antibodies. We've given now over 10,000 courses of monoclonal antibodies. Our rate of people getting hospitalized after that, even though many are high risk, is somewhere around 1 to 1.5%, tremendously lower than we would expect otherwise. So we do have therapy for those individuals that dramatically reduces their risk of having severe disease. But to be most successful, it has to be done within 5 days of symptom onset. So don't delay, call your healthcare provider.
Okay, good. So one non-vaccine related question, the new medication you described that had been studied here, both from a basic science standpoint and then some of the clinical standpoint, talk about that drug briefly again, and is it available or when will it be available?
Called molnupiravir. It is an oral antiviral drug made by Merck. We studied it, did some of the dose ranging experiments that in our inpatients, although it's really designed initially for outpatients with mild to moderate disease, led by Dr. Billy Fisher there. It's 2 doses for 5 days. Again, earlier with any antiviral, earlier is better. And it's said to reduce the risks of progression to more severe disease by 50%. So again, this will be something much easier. It could be when it becomes available, which I think it will towards the end of November, early December. It would be something that you could, one of your family members could run to the pharmacy, not you, because you're infectious, and pick it up, and will largely, to some substantial amount, help to decrease your risks of getting severe disease.
Okay, how will that drug fit with the antibody treatment then, as you think about what this is going to look like in a couple of months?
So we're handicapped by, of course, no head-to-head comparisons there. Initially, there's no, I don't think there's any indication we would use both. But what we will do is, with our experts, we're already beginning to work on developing algorithms. People who are young and at sort of moderate to low risk for severe progression, maybe a little bit overweight, mild diabetes, we'll send them to get the oral drugs because it's easier. People who are at higher risk for severe progression, unvaccinated, older age, underlying immune suppression, those will use monoclonal antibodies in.
Okay, so let's go back to
work out the exact criteria.
Yeah, but there'll be a role for both of them going forward.
There will be a role for both of them.
So you talked about what we expect in the next couple of weeks about in the school age, younger children, the possible recommendations. Kind of walk back over that. What are the possibilities that could happen out of that?
It's clear that many parents and the Biden administration would like to see the FDA and the CDC fully authorize vaccines for 5 to 11-year-olds. Of course, that doesn't compel anyone to get it. There would be a possibility that it would only be authorized for only higher risk children, meaning children substantially overweight, diabetic, immune compromised. I think that's unlikely, but I think they will be much more careful in their language to the physicians and those prescribing vaccines to have a frank conversation with parents about risks and benefits. Again, that's on an individual basis. On a public health basis, there's no question that immunizing these children is very important, because we know for many viral diseases that the children are the source for parents. And for those of you, like all of us, who have had young kids in daycare or in kindergarten, first grade, you know, children have 6 to 8 colds a year and they bring it home to you. And your biggest risk of getting those respiratory viral diseases is not from going to work each day, but from your children bringing it home. And so that will be very important, helping drive the rates down from a public health standpoint. I think clearly the benefits will exceed the risks, but it won't have the same dramatic differences that we've seen for particularly older adults.
Okay, good. So let's go back to the question of mixing and matching vaccines. You talked some about it already, but let's walk back over it. Right now, what's recommended for that 3rd shot is the PFIZER. That's information that's been presented relatively soon, the Moderna and J&J. Personally, so for any one of us that has gotten the PFIZER vaccine and not gotten the 3rd booster, is there advantage to waiting on Moderna? Just go ahead and get the PFIZER vaccine. or the opposite? If I've gotten, say, J&J, is there advantage for me to get one of the mRNA vaccines?
So right now, I would say, I might have said something different a month ago, even though realizing that was not allowed under the emergency use authorization. But I fully expect that both Pfizer, that the Moderna and J&J boosters will be fully approved by the end of the week, and UNC Healthcare will be giving it by early to mid next week. So I would just wait the few days. We'll have to wait and see. I personally think the data is highly suggestive that J&J getting an mRNA vaccine gives you a really good boost. But the options are several, and it's not clear which one to choose. One would be to give all the J&J people, and by the way, that time period will be 2 months, not 6 months, as with the mRNA vaccine. So almost everyone would be eligible. So the question would be, should they get a J&J and then at some point in the future, like at 6 months, then get an mRNA? If they get an mRNA vaccine, should they get 1 dose or 2 doses? And if they get the Moderna as a booster with the Johnson & Johnson, the Moderna booster is half the dose as the original one. Should they get the full strength or the half strength? So it's not straightforward, and I think we'll just have to wait till early next week to see what CDC says. But yes, absolutely, anybody with the J&J should get a booster, and that's also true, I think, with Moderna as well.
Okay, so a fairly frequent discussion that has had lots of overtones around it is the issue about ivermectin and whether it's really not effective, or it is quasi-effective, or it needs more study. So what are your thoughts on it right now?
So the NIH, the Infectious Disease Society of America, the FDA, CDC, all state that there is no role for ivermectin or hydroxychloroquine in the treatment of COVID, based on the current scientific evidence that harms exceed benefits. Although obviously it's always good to get more data. And the UNC Health, Pharmacy, and Therapeutics Committee only allows the use of those drugs for FDA indications and does not allow the use of those drugs because the first rule of medicine, do no harm, harms exceed benefits there, does not allow its use for COVID either. Keep in mind, we have many other therapies of proven effectiveness, and we don't, giving people drugs of clear harm handicaps the ability to give them the drugs for side effects and other reasons of the drugs we know work, and that is our focus.
Okay. So there's one question related to if you're able, with the different antibody testing, we know the number of people that have died from COVID, but the percentage of people in the US roughly that have actually gotten disease, what does that look like right now?
So we know that from the Red Cross study. So it's on the order of 20 to 40% of people in the US have had COVID there. Again, COVID is not fully protective, and some of those people get infected more than once. And I should say, when they get reinfected, the second case could be more mild, which is good, similar severity, but in some cases it has been much more severe. So having had COVID once not only doesn't give you as good protection as vaccine, it doesn't guarantee when you get your second case it's going to be a mild case.
Right, okay. So again, we're going to go back and you'll put on your hat with a crystal ball on it. Thinking in the future, you talked about the endemic nature of the disease itself. And so next summer, a year from now, is there a possibility that we'll need another booster, or is that just to be determined?
That's to be determined. If you look at the rate of which SARS-CoV-2 virus mutates compared to flu, it's about a third the frequency. So if we can drive the rates down, not only here in the US and worldwide, and drive down the rate of which new variants are developing, it is probable that we won't need a booster every year. We may need periodic boosters like we get with tetanus shots. At least that's my hope there. One of the reasons I think we did need a booster is, as you know, for all the vaccines, they were given the mRNA vaccines 3 and 4 weeks, the second dose after the first. And that's actually from developing immunity. It gives you faster immunity, but for prolonged immunity, that's really too fast for most vaccines. And there really aren't other vaccines that we take with that close a time period. So, you know, by giving people boosters for J&J at 2 months and for the other vaccines at 6 months, this may not only give us, will give us a much higher antibody level, but may give us much more prolonged protection with such that we won't need another booster like the next year.
Okay, so one last question, non-COVID kind of related, but not really. The flu season's here, flu shots are out. So what are your thoughts about what the flu season might look like? Because it was really different last year. And then what should people do about the shots themselves?
So everyone should take the flu shot. We had an enormous spike of respiratory syncytial virus, another respiratory virus, between about April and July, August. So even though it's summer, and again, that's because people had, particularly young children, hadn't had any experience with RSV and maybe some immunity. It filled up our pediatric hospital with a number of kids becoming quite ill. We have not had any flu circulating really in 2 years. And my two concerns are, one, it makes the vaccine we should get a bit of a guess how well it'll work, because normally we have a pretty good idea. Like right now, we'd say, well, how well did the vaccine work in the summer in Australia, their winter? And we don't have that experience really to know. So that's one issue. And people have not had flu in 2 years. That's another issue. And the CDC director and many of us have been very concerned that this winter we'll have a twindemic, as they call it, a big burst of flu and maybe some additional burst of COVID with Christmas, New Year's, traveling, family get-togethers, and other things. I don't think it'll rival the one we've just had, but it is of concern. And the other concern we have is there may be some shortages of the combined test kits that allow us to test both for influenza and COVID. So some concerns, and we're already busy planning, but I strongly encourage people to get their flu shot. And you can safely get both a flu shot and a COVID shot at the same time if you want it.
Okay, David, thank you. And as always, we appreciate you taking the time to share the information that you have and your knowledge and experience and wisdom. So I'll turn it back over to Leslie.
Thank you, Dr. Burks and Dr. Weber. That was a really fascinating presentation. We appreciate you being with us. If you are so moved by what you heard today that you want to help us, we're going to put up some resources here on the screen to make a gift to our COVID-19 response fund. And as a reminder, you will get a survey after the end of this call today. And then also the recording and slides are available for your use, and we will be happy to disseminate those out to you. So if there are any questions that you have of us, you're always welcome to reach back out. And again, thank you so much for your time today.